Good evening, everybody, and welcome all of you to the live program number 112 in Orthopedic Principles. We are back with our fantastic faculty, Dr. Amit Bhandarkar from Chicago, Illinois, United States. Today, Dr. Bhandarkar is going to discuss about deciding optimal cage for TLIFs. Amit is fellowship trained in spine surgery and worked across multiple centers across the world. Over to you, Amit.
Thank you, Hitesh. So let's go ahead and get started with the presentation. So today I'm going to talk about uh, how to decide which is the cage which is optimal for a transforaminal lumbar interbody fusion. I've been helped with this presentation by Dr. Harish Kempegowda. Let's start with the presentation. So before we go ahead with what cage to use, I want to talk about what are the objectives of interbody fusion. The objectives are just four. We want to have a distraction of the disc space so that we can achieve indirect decompression so that we can have enough room for the exiting nerve root. We want to enhance the stabilization of the spinal segment. We want to enhance the fusion of that segment. We also want to create and maintain the lordosis of that segment. These are the objectives of interbody fusion. It can be done by various ways. The most important workhorse in my practice has been TLIF. And today we're going to talk about TLIF, which is transforaminal lumbar interbody fusion. The evidence for cages in transforaminal lumbar interbody fusion is a little conflicting. There is not conclusive evidence. Do they alter lordosis and maintain lordosis is again controversial. The fusion rates, people say it's the same as posterolateral fusion. The evidence kind of points towards that direction. Same is true with the outcomes and complication. Uh, the evidence is conflicted in certain papers reporting the outcomes and the complications are the same in patients having posterolateral fusion without cages, and also similar in patients in whom we have cages. So, but there are some theoretical advantages that nobody can deny that, and this is an evolving technology, and we have evolved quite a bit. The theoretical advantage of the cages are anterior column support. It supports in the anterior column. It restores the disc height. It causes an indirect foraminal decompression. It restores the lumbar lordosis. It maximizes the fusion potential by having a contact between two end plates and a transit for the bone graft to achieve union. And if you achieve lordosis, it has been also said that it might help you in reducing the adjacent segment disease. So there are a lot of theoretical advantage. The studies which are limited in depicting all that theoretical advantage in reality, but uh, I will say this is a work in progress. So what we want to avoid while doing TLIF with these cages. We want to avoid non-union. We want to achieve nice arthrodesis at that segment. We want to avoid subsidence. We want to avoid flat back, which is loss of lordosis at that particular segment. And we want to avoid any cage migration at that area. So we want to keep this in mind as we discuss further cases. So the question here that I'm trying to answer is, should one cage that we usually use should fit all the cases that come to us, or is there some logical way of finding a right cage for one particular patient? And I think there is, and I think today I'm going to talk about how to select the right cage for individual patient. Again, this is an evolving science. This is how I do it. This is the rationales and the insights that I developed with my practice. I have learned from my mistakes, and I have been trying to be current with the current technology as I learn more about this. So, what are the problems right now that I'm trying to answer? So there is huge variability between the cage usage. There are a lot of different types of cage available also, and some surgeons prefer certain cages, some surgeons prefer different kind of cages. There is also lack of conclusive data regarding superiority of one cage over the other cage. It is also not established if different cages have different outcomes. So the rationale for using one cage over other is not very clear. And I'm trying to kind of put some things together, see if we can make use of these learnings to experience through experiences to come out with some rationale for using certain kind of cages in certain kind of patients. So I put forward two simple steps. The first step towards deciding what cage to use lies in characterizing the disc space. So as we do in preoperative planning, we need to find out how the disc space is, what are the characteristics of that disc space. And once we determine how the disc space is, we can marry our cage to that disc space so that there is an appropriate match, so that we can optimize all the objectives that I mentioned before after while doing the transforaminal lumbar interbody fusion surgery. So before we go ahead and study the characteristics of the disc space and how the cage options vary for those patients with different characteristics, let's find out what are different types of cages. So cage options are uh, numerous. I tried to summarize them and divide them based on material, shape, the size, if they are static or expandable, if they are 3D printed cages, or if they're articulating or non-articulating. So uh, this in combination may give to a different kind of cage. So this permutation combinations will create numerous cages. There may be a titanium 3D printed cage, or a titanium articulating cage, or a titanium expandable articulating cage. So there are a lot of permutation combination of this characteristic will give us a lot of cages. But let's see relative advantages, disadvantages of different types of cages pertaining to this particular characteristics. Materials. So the common materials used for these cages are titanium, PEEK, which is polyether ethyl ketone. There may be osteobiologic implants like the femoral rings. There may be combinations of this like a titanium coated PEEK. Then newer materials which are under study and they're recently been made available. One of them is the carbon fiber reinforced PEEK. The other being the molybdenum and resinium alloy and silicon nitride. These are the newer things. I think they will be the cages of the future, but I think right now, mostly what we have to decide is should we use a titanium cage or a PEEK cage for a particular patient. This has been an old debate. Titanium seems to be winning in that. You can look at this picture. You can see how much of an osteolysis happens when the PEEK cage is put in versus fusion, which is happening into a titanium cage. So the titanium cages are more durable. They don't break easily. They are biocompatible because they're hydrophilic. And now with the nano texturing of the titanium, the osteointegration is happening at a much higher rate. Uh, the titanium does have a high modulus of elasticity, which is not compatible sometimes with the adjoining bone, and it sometimes leads to subsidence. It also causes MRI distortion. PEEK, on the other hand, has a good elastic modulus. It gives a better fusion assessment while doing MRI or a CT scan afterwards. But PEEK is hydrophobic. There also is a controversy regarding a biofilm and osteolysis that forms around it, and and the fusion is a little controversial. If the PEEK, if it has a big surface area, it kind of prevents the fusion. People tend to put a smaller surface area PEEK implant so that they can pack the bone graft in the adjoining area. But the controversies, I think, is recently been won by titanium, which is porous titanium, which also has a nice modulus of elasticity, which is near the bone. They come in different shapes. Uh, they used to come in cylindrical shape, which were very thickened at the edges. There were a lot of chances of having subsidence with those cages. They are now trapezoid shaped, which is commonly being used, which has a greater surface area. Um, The two main shapes for which we want to decide is it either a banana shaped cage or a bullet shaped cage that we should use. And the mesh shaped cage are more economical and has been used. Again, they have nice graft window, but they are high chances of subsidence. So banana versus the bullet cages, the advantages and disadvantages. So advantages are uh, the banana cages maintain good lordosis as compared to the bullet cages, but they are difficult to insert. They have a large footprint, they have less cage migration, and they are positioned nicely into the anterior segment where they can kind of put a lot of uh, surface area and a stronger and bear nice stress into that area. The bullet cages are easiest to insert. They are usually in the center, so they cannot bear the stresses in the center area and more high chances of subsidence there. Um, but they require less manipulation of neural tissue while insertion. They can be placed like PLIF. The most important advantages I see with the bullet cages is that they're so easy to insert, and banana cages, I think sometimes it's difficult to insert them in the right area. So the banana cages disadvantages wise, they're difficult to reposition. They have to be placed very anterior to create proper characteristics. Their entry point should be proper so they can be rotated to lie into the transverse plane properly. Um, the disadvantages of the bullet cages are they are inferior when tested alone. Now we have to understand that all the testing being done are uh, testing done with the cages only inserted, but usually in real life we insert pedicle screws, and uh, if you test a banana cage and a bullet cage with the pedicle screws inserted, there is not much changes into the biomechanics of the construct. They're stiffer in every aspect, and they're similar. There is a less restoration of lordosis with the bullet cages. There are chances of cage migration with the bullet cages, and there are more chances of subsidence because it's placed in the central area. The anterior apophyseal ring area is much more harder and can bear more stress. Again, the main thing is that the construct stability remains the same once pedicle screws are used, and they give both similar stability. Now, it's very important to have a good inserter if you're using and a big fan of banana cages. So there are certain characteristics of a inserter. So if you have a good cage but does not have a good inserter, it usually will not give optimal result, especially when doing MIS TLIF. We need a good inserter which is nice and articulating, which can go ahead and uh, kind of loosen up when we insert, and at the same time we should have the capacity to tighten it up so that we can cantilever it and make it horizontal. It should be narrow so it can go through a narrow tube, and should be offset so that we can see the window clearly while inserting the cage. So these are the characteristics of good inserter. We need to have a good inserter while doing this banana cage especially. Now, the desired placement of the cage. Where do we need to place the cage to uh, obtain certain benefits? So there are two cage placements. One is anterior and posterior when we study the lateral views. Uh, the anterior placement, as I said earlier, when it's placed into the anterior apophyseal ring area, which is a little thicker, there is less subsidence. So posterior, there are high chances of subsidence. There's also high chances of extrusion or a posterior cage migration with a posterior placement. There's a better lordosis correction if the graft is placed or the cage is placed anteriorly. There's a poor lordosis correction with a posteriorly based implant, but it causes good indirect decompression if the cage is posterior. The ideal placement, if you want to create a lordosis with a cage, it should be in the anterior side. The center of the cage should be anterior to the center of the disc base. This is very critical to understand. If the center of the cage is posterior to the center of the disc base, the patient usually uh, develops a flat back. So, but it causes more indirect decompression to the foramen. So we have to balance these two things out. Usually we need to find out for a particular patient what is required more. Uh, and But for lordosis, definitely anti-replacement is much more favorable. Now, what height cage to be used? Do we over distract? If you over distract, usually it causes end plate trauma because the cages again have, from the TLIF has a very smaller surface area, and we usually are tend to uh, trending towards inserting only one cage. Initially, there were two cages, like PLIF cages being inserted before, but I think studies have shown that the construct wise they are similar in stability, hence we want to now only insert one cage, and one cage with a relatively less surface area. If it's over distracted, causes a lot of end plate trauma. If it's too thin, there is a chance of cage migration. So I think also other things needs to be kept in mind while deciding what size to be used. Sex of the patient, females usually take lower size cages, the body height of the patient, the location of the pathological segment, and also the height of the pathological segment. These are the factors that will help us to decide where the cages will be put. Now, the very important part of today's lecture is going to be the evolving technology of the expandable cage. The expandable cages are just revolutionizing the minimally invasive spine surgery. Um, Here, the expandable cages can be of different types. They can be articulating, they can be expanding mediolaterally and also craniocaudally, or just craniocaudally, or they can be in terms of like screws which kind of circumferentially enlarge. And this is like a cage which can be post-filled, so it expands and then we can post-fill it with morcellized bone graft. So this is the revolutionized new world of expandable cages, and we need to know more about it. There definitely has advantages. You can look at this bottle with the ship. It goes with a small opening, and then it opens up and takes its form. It causes less neural retraction. Uh, there is a very ease of insertion because less window is required. Cages can expand in both direction, and it prevents trialing. And it also causes less end plate damage. If you imagine if you're putting a big cage through the Camin's triangle, it's going to push on the exiting nerve root. It's also going to cause the end plate damage. Um, the static, on the other hand, has a more chance of subsidence because you're putting a big cage, definitely damages the end plate. But if you slowly expand it, it does not cause that end plate damage. It also requires more window as compared to the expandable cages. But the good point is that they're relatively cheap. Um, So what is the evidence of using expandable cages over the static cages that we have been using for a long time? Um, there has been convincing evidence that the expandable cages do increase the disc height better than the static cages. The cob angle, there are conflicting evidence regarding that, and the foraminal height increase also, there is a conflicting evidence, but it's trending more towards the expandable cages. But again, the evidence is still coming. These are relatively new technologies, and I think in the near future we will get more convincing evidence for the expandable cages. Uh, One of the problem with the expandable cages is that once we have those expandable cages implanted, there is a torque limiting um, screwdriver that prevents too much expansion and hence the subsidence. But also at some time, if we are not able to expand the cage to its required capacity, we may not be able to achieve that gain that we were intended of that we were planning on getting by doing expansion of those cages. There also have been reports of collapse of the expandable cages after expansion, and there are some companies actually who have withdrawn those expandable cages from the market because of that collapse. It's very important to understand this technique of expansion of cages, and we have to understand how it expands. So it can have a lordotic expansion. So this cage goes in parallel and then gets expanded into lordosis. And this cages actually go on lordosis, and there is a parallel increase in height. So there is no increase in lordosis further with expansion. And this is just like a car jack where it increases the disc heights. So the expandable technology is all the cages should not be seen in the same light. They have different biomechanics that they provide to that disc space. We need to select, do we need to have a lordotic expansion or we need to have a parallel expansion beforehand? Um, I think it is all decided based on how the cage is shaped, how the disk space is shaped, and how much of a window we have into the posterior side to insert the cage. The future, the best cage in the future is possibly going to be an expandable banana cage. It has been shown that it creates the best lordosis, I think much better than static cages. And also it creates best foraminal decompression than other static cages if placed in the midline or middle of the disc space. So if it's placed anterior, it creates a nice amount of lordosis. Um, Now, one of the advantages of this expandable technology is that the window is reduced, and this can be now used to do endoscopic fusion, which I have been using in my practice. Uh, we can do nice disc prep through a narrow window, uh, and then we can go ahead and insert these cages, which can be expanded, and then we can post fill those cages to create a nice fusion. We also need to know there are different uh, technologies which has evolved with time to achieve more osseointegration. One of them is 3D printing. Other one is plasma spray of the titanium or the peak. Then there is a porous peak. So there are different kind of technology which is coming up to enhance the osseointegration. But one of the key thing here is this nice mesh structure with struts here kind of help the cage to bear the load in a better way. So it does not kind of create any stress riser for the subsidence. And this has a nice graft window, which can really help uh, faster fusion at those locations. They have more graft window, they have less subsidence, they have better osteointegration, and they also have, most important, decreased modulus of elasticity of the whole construct so as to achieve greater union. After understanding the different types of the cages that we have and then relative advantages and disadvantages of those cages, now this is the most important slide. So when a particular patient comes to us, we need to characterize the disc space. This is the most important aspect of deciding what cage to use, because that variable of a different cage usage may do have a bearing on the outcome of the patient. Again, the evidence is not clear on that, but with practice, I have known that different cages and really do influence the final outcome of the patient. So I will discuss some cases after I go through this characteristics of the disc space that we need to keep in mind when we decide what cage we need to use. The characteristics are disc height. Obviously, if the disc height is low, we have to use certain kind of cages. If there is a lordotic disc space, if say the cage is fixed in lordosis, maybe we have to use an expandable cage which opens in lordosis. Uh, we need to find out how much of a lordosis requirement is there. If there is a huge lordosis requirement, we may have to use a banana cage, which is possibly placed anterior. And if it's articulating or if it's expanding, we will be able to get more of a lordosis. We need to find out what is the shape of the end plate. In certain end plates, if they are uh, concave, I think nice convex or biconvex cages fit pretty good into those areas. If there's end plate sclerosis, I think a peak cage may not be a good choice because it may not help with union. We may have to have a nice titanium cage, which also can be used easily because the sclerosis of the end plate may prevent any subsidence. Soft versus hard disk, we need to know. Um, Again, to know the mobility of the disc, we need to know how narrow is the posterior entry zone. If the entry zone is so narrow, we will possibly end up damaging the end plate while end plate preparation, and hence we need to know that. We also need to know how much of an end plate area the patient has, because we need to plan regarding the length of the cage that we need to put in. Spondylolisthesis, if it's not reduced, and if you put a cage which is posterior, is more likely to extrude. Uh, Decompression, if it's needed, basically the endoscopic option is out. Uh, and if there is a contralateral or a facet hypertrophy, the Camin's triangle is substantially narrowed down. Um, and if there is a contralateral decompression is to be needed, a nice centralized cage can be easily placed. So these are all characteristics that we need to keep in mind. Um, and we'll discuss more when we go through these case examples. And also patient characteristics like the BMI. Obviously, if the patient is high BMI, do a MIS surgery usually saves me a lot of struggle with the open surgery and saves me a lot of complications too. The age of the patient has more chances of having subsidence. Same with bone marrow density. If it's low, high chance of subsidence, we want to avoid that. We need to keep that in mind while deciding the cage. And if the patient is at risk of pseudoarthrosis with a smoker, I think I rather will avoid the peak cages. In my practice, I have started using more and more titanium, porous titanium cages to avoid this complication. Now, let's take this example. This is an elderly patient with osteoporosis with minimal posterior window. So you can see that the problem here is the patient has spondylolisthesis, patient has spondylolysis, and an almost bone-on-bone appearance there with a very narrow posterior window. And above that, the patient is very elderly with other comorbidities as well. So what interbody device should we use? Well, I went ahead and approached this area transforaminally, and I was able to use what we call as bag of bones. And I was able to get nice disc height restoration. I was able to reduce that bone a little bit. Again, this bag of bones provided a huge surface area. So because the patient was elderly, I was worried about subsidence. I was worried about putting a titanium cage there, which might subside. I've saved the day by using a bag of bones. Again, my window was very small, and this bag of bones nicely expanded, and I think the surface area was it's so big that it kind of evenly distributes the stress around that area. So this is again one of my go-to kind of implants when the patient is very elderly, with the disc height is immensely reduced, and uh, and if the posterior window is small. Similar patient, again, patient has decreased disc height with osteoporosis, old lady with multiple comorbidities. Again, this procedure is pretty quick, so you can really finish the surgery in maybe 1.5 to 2 hours. Because you can really get access to this area, even though it's completely bone on bone, by putting a needle and into that area, and then going ahead and putting a dilator there, and kind of nicely. You don't need much of a disc prep because this area is almost doesn't have any disc material. But I can watch that disc prep with the endoscope too. And you can pack that with that bag of bones, and it gives pretty good results for the patients. Now, a patient with around elderly patient with a mobile spondylolisthesis with osteopenia. Now, this patient, I was able to go ahead and treat with uh, uh, peak cages. Again, this was long back. I moved away from those, but again, this is nicely anteriorly placed a cage at L5S1, and not complete reduction of spondy at L45. Again, that puts a little risk of a posterior cage migration, but the patient is still doing okay. Osteopenia, I think uh, in patients with osteopenia, I would like to prefer a peak cage is inserted there. So this is one of the things that I considered before preoperatively, before deciding the cage, and I think the patient is doing okay. Now this is one of the other examples of the choice of cage. Now this patient, if you see here, this patient is extremely obese, around 45 BMI, I would say, with a lytic spondylolisthesis, which is mobile with good disc height. Now that disc height was so good that I was able to approach that transforaminally easily, and I was able to use a expandable cage that can go through this tube rather than using a bag of bones. And this patient was young uh, and nice bone density. I was able to go ahead and use this expandable cage, which was endoscopically put, and I was able to save any major open surgery, and all the procedure was done within 2 hours, and the patient is doing pretty good. So this is the new frontier. Like, so any patient with a high BMI, a young patient with a good disc height, I think my preferred choice will be expandable, um, kind of expandable lordotic cage done endoscopically. So this is what is the Camin's triangle. You can see that is the Camin's triangle, and this is nice and wide up here, and it can be easily approached under fluoroscopically, and then we can go ahead once the guide wire is, we can thread a dilator and do the disc prep and go ahead and deploy the cage. Now, this is one of the cage again where the endoscopic TLIF, which is different cage, now it's a peak cage. Now, is being deployed here. Again, this patient, I wanted to do endoscopic approach. This is because the patient had a huge tarlosis there, and it has almost eaten up the pedicle. There was no pedicle on the other side. So I kind of used a facet sparing approach onto the other side. I wanted to preserve that for extra stability. And because there was no pedicle, I was not able to go ahead and put any pedicle screw there. So I preserved the facet joint and went ahead and deployed a peak cage. Again, the patient was osteopenic. I was not confident that if I expand any lordotic cage, the patient is going to go ahead. I thought it's going to have a subsidence, so I used this, and the patient did pretty good. Again, there is a controversy in the literature about using a unilateral versus bilateral pedicle screw after TLIF. I think the construct is less stiff with the unilateral pedicular screws. Again, there is a debate about it. People do recommend either putting some kind of cortical screws or facet screws, or the best will be a counterlateral pedicle screw as well. Now, if there is a requirement of producing high lordosis at that segment, again, we need to understand that TLIF is limited in how much lordosis it can give. The best of the retrospective reviews has shown it produces around 7 degrees of lordosis, which is very less. The expandable technology is now kind of giving a chance of getting a 10 degrees of lordosis at a level. There are hyperlordotic cages, but they are not without complications. So if the too much of a lordosis is needed, maybe TLIF is not the best option at that present time. Maybe the patient needs or deformity correction surgery, maybe needs a bilateral facetectomy. So if you want to optimize the lordosis at a segment, what we need to do, we need to put the cage anteriorly, possibly a banana cage, and we need, if that banana cage is expanding, it will further produce more lordosis. Other option is using an articulating cage, which is placed anteriorly. So there is a lot of talk about lordosis and TLIF. There are a few points I kind of reviewed the literature. Again, the literature is not very conclusive about most of these things, but it's trending towards these findings. What I quote here: the lordotic cages are better than straight cages to create lordosis. Overall, TLIF causes increase in lordosis. Initially, it was thought in some papers that it actually decreases lordosis. But if we study the data properly, the patient who had increased lordosis preoperatively, they tend to lose some lordosis. The expandables are better than static cages for giving lordosis. Anteriorly placed cages do better. The banana-shaped cages, the placement is better for creating lordosis. There's some of the examples of articulating cages that I often use in the practice. This patient needed some lordosis here, nicely done here. Now, this is a lordotic expansion. So what happens once you expand lordotic cages, there is always a chance of subsidence. So we need to keep that in mind, because uh, once you start expanding at this location, if this end plate, if the patient has a soft bone, it kind of starts subsiding. But the good part of this cage, of articulating cage, is that even though it's subsided, it has given nice amount of lordosis uh, up there, because this part again goes to a robust end plate area. Uh, I think this is also one of the good implants that I use when provided the bone density is pretty good. I think it can really go down low and and create a lordotic expansion. There are some cages in which I need a parallel expansion, so I put a lordotic cage, and I will show you example of that. But this is a patient in which the preoperative disc space was lordotic, and I wanted the narrow posterior window, so we wanted to put a cage that can expand in lordosis, and this cage kind of serves that purpose. Even though there is a subsidence now, the cage is still doing its job. So again, this is just to remind us, we need to look at a lot of this characteristic of the disc space before we decide the cage. You have to look at the patient characteristics as well. This other example, again, this is bone on bone, narrow posterior window. This is a young patient with a sclerosed end plate, a patient at high BMI. So the high BMI, I usually try to do AMIS TLIF on them. A young patient with sclerosed, I'm going to use a titanium one. Again, there's a narrow posterior window. I'm going to use expandable cage on her. And obviously, the L5S1 area, I want to have nice amount of lordosis there. There's a requirement for lordosis. So what I did a similar articulating cage up there, done to a MIS TLIF area, and a nice restoration of height and a lordosis at that level, and the patient are doing good. A similar example here, but with extreme severe spondylolisthesis, long time neglected, almost no room for the foramen here. And I really wanted him to have some lordosis. I went ahead and did an open surgery on him, bilateral facetectomy. Again, but the window was very small. Again, the exiting nerve root is right here. I cannot use a bigger cage. So this came to my rescue, also created lordosis. I think this is one of the advantages of lordotic cages. Again, in this patient, because I was aware of the fact that I may torque the screwdriver early on and I will not be able to achieve required lordosis. Hence, I used parallel expanding cages, which had a fixed lordosis to them, instead of using a cage which expands in lordosis. Other example I can show you is a routine case that we usually get is spondylolisthesis. Nice disc height. This is a lying down MRI. The disc height is pretty good, even though it looks kind of compressed up here. Patient had huge facet arthropathy, so no room for me into the foraminal area to do a endoscopic TLIF. Her bone marrow density also is a little low, and her disc height is well maintained while lying down. It's a nice mobile disc, and patient does need lordosis at that segment. So I went ahead and did a nice facetectomy at that area with a tube dilator. I wasn't able to use, again, because the patient's bone density was low. I did not use a lordosing cage, but I used a parallel lordotic cage. So it came with a prefixed lordosis. I was able to go ahead and use a distraction to go ahead and put the cage in. Once I put the cage in, I parallelly uh, uh, opened it up because now patient has low bone density. So I went in very low and opened up nicely uh, with nice contact here. And I was able to post fill that area as well. I was able to reduce the spondy as well and get nice lordosis here. The only pattern is that the coronal deformity has not been respected. I went through the concave side. Uh, I went to the concave side, and I think I still did not get much correction up here. Um, but again, uh, the patient do take some time for their pelvic tilt correction after the surgery. I'm still expecting the patient will do better with time. So this is again, to understand this, the patient cage was lordotic to start with. The lordosis remained the same, but the height did increase. Now, we also need to talk about some complications. So this is one smoker patient, had a possible decreased disc. uh, Cage height was inserted here, had repeated falls, uh, and this happened. He had extruded of the cage. I think usually I try to go from the other side or maybe even do XLIF or ALIF on this patient, but I was able to go ahead and salvage this patient by doing a banana cage to the same side, and I used titanium with little increased height, but the patient has been stable since last few years. Now this is again one of the failures. This patient had a increased lordosis because of increased thoracic kyphosis. So patient's need for lordosis were immense. Um, Now this is a bad choice of the cage. It's a metallic cage in a patient with a low bone density and a high pelvic incidence. Again, it's going to subside, and it did subside. And those cage were not put in the front, but rather put into the posterior side. And kind of that put a lot of stress there. In the cage, if it would have been here, it would have been a much better lordosis correction. But again, the patient did have huge requirement for lordosis. I think the best cage would have been here a expandable articulating cage, uh, which does not put a lot of uh, pressure into the end plates. And the peak cage also would have been better if it had been placed here into the anterior side. Maybe a banana peak cage would have been better as well. So these are the things that we need to keep in mind when we decide about what cages to use. Again, one of the failures here, in very nicely done cage. This cage has a nice titanium nanostructure, as you see here, with creates a lot of union. The patient is a smoker, had multiple falls after initial surgery, and this cage kind of little backing out where it was inserted from. And possibly this cage, again, the problem, if I want to kind of split hairs, is that does not have that tight 3D printed mesh structure, which kind of distribute the stress evenly to the cage and does not give any stress riser leading to kind of subsidence like this cage, even though it is a huge graft window, patient being smoker. I think a 3D printed cage would have been a much better choice here, placed more anteriorly. This was very nicely placed anteriorly, but again, somehow that edge created a lot of stress rising on this patient, especially after the fall. Um, this is one spondylolisthesis patient, old smoker. Again, we also wanted to correct a deformity here, the coronal deformity nicely corrected here and very nicely placed cage. Should have been more anterior, uh, uh, but I think she's doing much better. And this cage was slowly expanded into lordosis. Again, I also went with a parallel expansion cage, not a lordotic one. Now, this is one of the other patient that I wanted to show you, that the patient has a foraminal disc and also a lytic spondylolisthesis at that location, or kyphotic disc space up here. So we wanted to have lordosis. We wanted to have complete facetectomy here. And we also wanted to have um, a nice union at that level. The patient was smoker. The best thing I thought about at that point of time was The mesh cage, again, the patient had a nice posterior opening, unlike the other patients where there was a posterior opening was low. So I kind of went away from expandable cage. I wanted to place the cage as anterior possible. I was not 100% able to place that anterior, but it was nice lordosis was obtained. It was nice contact. And the patient's decompression, the thorough decompression was done for the foraminal, extraforaminal disc. And this cage has been working good. So these are the other examples of those uh, uh, mesh cages that we have, or kind of titanium 3D printed cages uh, that were implanted. Nice implantation, less subsidence chances, nice graft window to cause a bony union. So all young patients who are very active. The best cage in the future will possibly be the cage which has a nice graft window and which is expandable, which expands when placed into the anterior side. So it creates much more. I think this one is a hydraulic cage which creates more lordosis after implantation. So what is the ideal cage? So ideal cage is ideal for one particular patient. It's not ideal for everybody. But I think there is going to be more choices coming for individual cages. But ideal cage is the cage that matches the need for that particular segment. Some characteristics we want to go by, that it should be inserted through a small corridor. It should be expandable. I think this is the new thing. It's going to revolutionize the TLIF, and I think it already brought the endoscopic TLIF option to us. It should cause good osseointegration, so the nano structuring of that cage, possibly titanium should be that. It should facilitate osseointegration. There should be low modulus, maybe porous titanium will be a great option. There should be a less neural retraction, as we talked about with the expand, because of the narrow window. There should be less trialing so that we do not insert too many things in the disc space. It reduces the chance of infection. It should we should be able to distract and create lordosis. It should be MRI friendly and should be easy to revise if it migrates. So these are the characters of ideal cage, and I think we are slowly inching towards it. Again, it's in the summary, I will say while deciding a cage, it is very important to study the disc space, its characteristics, the height, the sclerosis, the patient has spondylolisthesis, how much of a lordosis is needed, how much is the posterior opening, how much is the end plate area. This all do have a bearing on deciding what is the best cage to use. We also need to see if the patient has a high BMI, and the high BMI, obviously, my choice of approach will be possibly endoscopic if the disc height is good, or a MIS TLIF for the patient. We also need to find out, is the patient high risk for pseudoarthrosis or subsidence, and we need to kind of use a cage appropriately based on that. I think that's my possible rationale to decide what will be the best cage or optimal cage for one particular patient that presents to you. Let me know if you have any questions.
Excellent, Amit. Another cutting edge lecture looking into the future.
Well, yes.
Amit,
I think.
Questions?
Go ahead.
See, what are the indications for using these interbody fusions? You have demonstrated spondylolisthesis, but some of your X-rays do not show the translation. It's just the narrow disc space. So, what are those indications that you look for when you think about interbody fusions?
Right. I think, as I said, the objectives for interbody devices are very clear. So, if you want to achieve good stability, they are required. If you want to achieve good fusion, they are required. If you want to do an indirect decompression of the exiting nerve root, when the narrow disc space is there, the exiting nerve root is kind of compressed. The best way to decompress them is by increasing the disc height, and that a TLIF can achieve that. Obviously, we can use them in spondylolisthesis to do the same thing. So these are some of the objectives of doing interbody fusion. So maximize fusion, maximize stability, indirect decompression. And the other most important thing is that now we are toying with that more is sagittal balance correction. So we can sometimes, expand it or put a lordotic cage there, and it may improve the patient's sagittal balance.
No, suppose for a postgraduate perspective, he wants to know what are the what are the disease conditions? Someone asked him, what are the disease conditions where you're going to think about using a cage? Okay, you
Right.
mentioned the
So,
spondylolisthesis. Anything else? What are the other
right.
ones?
So basically anything for which a fusion is indicated. Cage insertion is a part of fusion. So we are optimizing fusion. For anything for which a fusion is needed, I think a cage is always an option. So it's not about indication for cage, it's the indication for fusion for a postgraduate perspective. A particular patient uh, has spondylolisthesis, a mobile spondylolisthesis, or the patient has a severe discogenic pain, has exhausted all the conservative option, or the patient has a compression of the exiting foramen from the decreased disc height and needs a disc height restoration. These are some of the options for fusion too. So when the fusion is decided, then the cage becomes a good option. I'm not saying that the posterolateral fusion does not work, okay, but but cage optimizes a lot of things what a fusion can achieve.
There are a lot of lifts. Say there is an A-lift, there is a T-lift, there is P-lift, there is X-lift, and there is 360-degree fusion. So can you just give a short description on what are the differences between these and where are these best suited?
Right. So the approaches decide the name. So if it's an anterior fusion, it's A-lift. Okay. If it goes from the front side, if it's a posterior fusion, it's P-lift. If you remove the facet joint and go to the foramen, it's T-lift. If you go trans-psoas, is lateral lumbar interbody fusion. So there are relative advantages and disadvantages for that. So L5S1 and L45, which are the common segments which are involved in a lot of degenerative conditions, I think this levels are mostly suited for posterior approaches, and I think TLIF has become workhorse for most of surgeons, because ALIF, even though it's superior in certain aspect, needs an extra surgeon who requires to give an access from the front, and there is some vascular risk involved. So I think the TLIF is workhorse for these two areas. Now, lateral lumbar interbody fusion in my practice, anything above L3-4, anything above L4-5 is lateral interbody fusion, or even oblique lumbar interbody fusion, which is anterior to psoas, because this has a good surface area for the cage. A bigger cage can be implanted, a nice sagittal coronal correction happens there. I don't need any access surgeon to do that. So I think that's how I do it. Anything above L4-5, I do a lateral or a oblique. Anything below L4-5, the L4-5 is favorable anatomy, say it's high up above the iliac crest, I may even still do a lateral at that level. Otherwise, I will do a TLIF at other level. ALIF is an option which I have to kind of find out the calendar of the vascular or access surgeon, and it's kind of a hassle sometimes. But ALIF also has definite indication as well. But usually the workhorse right now, easily done, risk-free surgery, and most of the people, spine surgeons, are well acquainted with that, is a TLIF surgery.
And what about 360 degree? What is that exactly?
So 360 degree means like when I do a TLIF, say I'm doing a MIS TLIF, I also go ahead and do a posterolateral fusion to the same paraspinal approach. So usually it's not as great of a fusion as people used to do with the open surgeries, where they would expose all the way to the tip of the transverse process and use a burr to decorticate that. Maybe the aggressiveness of bed preparation is not that much in a MIS TLIF, but still when a 360-degree fusion means you do an interbody fusion and also do a posterolateral fusion at the same time, that gives you a 360-degree fusion.
So that's an intertransverse fusion plus interbody, is it?
Yes, so interbody fusion plus intertransverse fusion.
The other thing is, what is the use of the BMP? I know there is a lot of debate in the US. At one point of time, Eugene Karagi came out with the problems of BMP, like carcinogenic and all that. So is it still in vogue in the United States?
Well, I have not used it in my private practice. I have not used it in my fellowship. It was around 7-8 years ago. We used to use it in certain patient. I think it has been used less and less because of the cost. number one. And second thing, it shows evidence of osteolysis in some certain patients. And at that point of time, people had some problems with the dosage, how much to use. Now there are ultra small doses are available, and they are being used. And there are some evidence available in literature about BMP causing some complications into like cervical spine. We do not use it at all because it causes a lot of vascularity at that location. ALIF in males was related to some retrograde ejaculation. So there are some complications that came out with BMP, and there was high cost associated with that. Osteolysis is the major problem with the BMP. But still, I think it is a go-to if you have failed fusion, pseudoarthrosis. I think a ultra low molecular weight, sorry, not ultra small amount of a BMP, ultra small dose is now available, which can be used to achieve fusion.
Amit, you know, my very good friend, Mr. Murli Venkateshan, he's a practicing spine surgeon in Apollo Hospital, Chennai. He's also in this Zoom room. And Murli, are you there? Murli has sometimes, yeah, Murli's around. So Murli, this is Amit. He's in Chicago, Illinois. And Amit, this is Murli. He has done a lot of work when he was in Nottingham, and now he's in Apollo Hospitals, Chennai. Murli, your questions to Dr. Bhandarkar.
Hitesh, can you hear me?
Yes, yes.
Yeah. Hello.
Hi, Amit. It was nice to listen to your overview of cages selection. Everything was good. See, I see you use a variety of cages, right, and I see you use variety of techniques as well. I've seen the MIS and endoscopic TLIF as well. My question is L5S1. When you do endoscopic TLIF, because even with a discectomy, we interlaminar is the preferred method. And how do you do a TLIF, endoscopic TLIF at L5S1?
Oh yeah, that's a very good question. So I don't do transiliac or anything like that. So, but I have got used to, I will say that. So I in my practice, I do a lot of pain injections. So I like with time, L5S1 was a difficult area to target, the Camin's triangle. But with time, I think I got better, and I think I got confident. I think I use a special oblique view with a direct window view, I call it, to that Camin's triangle. I'm able to visualize that. And if I am able to visualize that with the patient on bed, with no iliac crest coming in there, and I say I got the window, and I think it's pretty straightforward from there. But there are some patients, obviously, where the iliac crest is very high. And usually I do injections on those patients before I take them for surgery. And if I don't get a direct view to that area, I may not do this endoscopic fusion on them.
Okay. I also see the unilateral instrumentation. See, we do unilateral instrumentation for the pedicle instrumentation for the TLIF, and but our selection criteria is very stringent, and we don't use unilateral instrumentation if they are osteoporotic.
Yeah, me the same. The patient that I shown you, that patient did not have any pedicle on the other side.
Okay.
So I was forced to do unilateral. I'm not a big fan of unilateral fixation. I do bilateral fixation in all my patients.
And what do you use for, because you don't like the back of bones, so what do you use then? What is your combo? When you do MIS or endoscopic fusion for the grafting, what allografts do you use?
Oh, I mix 3-4 things. I think one of the things that I use is a demineralized bone matrix. I use locally harvested bone shavings, which is a local autograft.
Bone debris you will use, yeah. Okay.
Bone graft. Then I mix them with the bone marrow that I do from the pedicle when I put the screw in. And if the patient is kind of a potential for pseudoarthrosis, I may go ahead and use their iliac crest bone graft from the PSIS too. So I make a small incision and harvest through that too. And there are also bulking agents which are synthetic. Sometimes I use them too. So I use a mix of all these things. I kind of use a funnel to post pack it and pre-pack it, and I try to achieve fusion. Also try to put something into the posterolateral gutter as well.
So see, we use only the local graft because everything adds cost here is very cost conscious when in our setup. Mostly the allografts bone chips, and they do very well. In a selection case of high risk non-union cases like smokers or any non-union cases, then we use the demineralized bone matrix, and BMP is expensive. So BMP, DBX and the BMP we reserve for highly selective cases. Rest all is all we for bone grafts.
To tell you the truth, I have not used BMP in last 6 years. Not used at all. So BMP, not like, I think iliac crest bone graft is the gold standard for me. And I think the only thing is that I refined my technique. I go ahead and use a very small, I will say 5 millimeter incision onto the iliac crest under Siam guidance. And I think we have a specific tool to harvest the cancellous bone from there. That's my go-to if the patient is very high risk of pseudoarthrosis. Other than that, I think a demineralized bone matrix is just a bulking agent for the localized, autograft, which is morcellized that I'm using.
See, we also do injections. That is an option for the patient, but when you, for your endoscopy TLIFs, do you always prefer to do injection before, or is it a necessity that you have to do the injection procedure to, in order to go to the next level?
Very good question. So I think usually if I am planning an endoscopic approach on anybody, I would like to go ahead and do an injection on those patients. And also it's kind of a double benefit from that. If the patient gets temporary pain relief for at least for a day or something, that gives me huge confidence that the patient is going to get better by doing that. And I think it also helps me to plan the approach,
Okay. And is the trend in moving now from PEEK to titanium, or what is it?
So PEEK, there is a trend because titanium itself has improved quite a bit. So the first cages, the BAK cages were titanium, but now the titanium, there is a porous titanium available. There is a titanium with a new nanostructure available. Now all the expandable cages are titanium. There are also porous PEEK. There is also a lot of other stuff which is coming up, which kind of, they say porous PEEK absorbs the water, like is kind of hydrophilic. But there are still a lot of animal paper which show that it does cause biofilm. It's still hydrophobic. It's not biocompatible. It doesn't fuse where the PEEK cage is, but fuse around it. So it's very important to kind of keep that in mind. I think it also has a lesser durability or strength than the titanium. I think titanium is going to win this race.
I think initially we started with titanium, then PEEK came as an attractive viscoelasticity to the bone and some things, and then now we are moving to titanium again.
Yes,
I think as you said, the cycle is moving.
The modulus of elasticity with the porous PEEK, if you get a banana cage, which is a porous PEEK, and if you put there, they say the modulus of elasticity is pretty good. It's not as high as a pure titanium cage. So the porous PEEK is the way to go. And there is there are a few more new implants. So one is known as MORI, M-O-R-I, which is a molybdenum and resinum combination, which is coming up, which its modulus of elasticity is as good as cancellous bone. The porous MORI. So I think, and its strength is much higher than titanium. So, and much higher than cobalt chrome. So I think these are new alloys which are coming up, which possibly may take the
So see, for us here, the PEEK is a bullet cage is a standard, and banana cages we have titanium, and expandables are just come into the market. Yeah, so the availability of the spectrum of cages is very limited in our part of the world, and we hope we get whole armamentarium into our practice as well, but cost has to be built in. See, one thing I want to, before we go, see, we all, you said the disc height, cage, we bring in indirect decompression, we make the X-ray look good, restore the foramen, everything. But I'm still not convinced to have a very concrete evidence to say instrumented and non-instrumented or interbody then TLIF is better. What looks X-ray may not be necessarily adding superior outcome for the patient, because that is the debate always we have every time we talk about interbody cage. So I don't know what is the perspective in America among the spectrum of surgeons.
Yeah, I think you're very right. There's a lot of the radiological findings do not match with the clinical findings. Even though you have a good X-ray, do we have bad patients? Yes. Or bad outcomes? Yes. So I try to minimize that again by trying to find. I think previous lecture I talked about finding where the pain is coming from. Basically, I have become pain surgeon. So so being a pain surgeon, one of the main job is to find out where the pain is coming from. So if I find out if the pain is coming from facet joint arthritis, okay, because of mobile spondy, so and then what I do is that I go ahead and do an injection in the facet joints, or identify the pain generator, put an injection, and the patient gets temporary pain relief, gives me a lot of confidence. I kind of give them a trial. So again, I'm not after treating their MRI, but I'm after treating their pain generator. So once I identify the pain generator, I think the results have improved quite a bit since I started doing that. And I think, as you said, the X-ray picture is it's secondary. The most important for me is comprehensive. I think comprehensive treatment for the pain generator, which is so. For example, I think with the cage and all those things come into play when, say, patient has a lot of flat back, or say loss of lordosis at that area, and having a lot of pelvic tilt to maintain a sagittal balance at that particular point of time. So I have seen that the moment we restore lordosis and we take efforts by inserting this cage and doing things to restore lordosis at that area, I think the long-term pain relief and the outcome definitely changes. The patient's pelvic tilt changes, his effort to stand and walk around changes. So I think looking at a pain surgeon perspective has helped me quite a bit in solving that problem. Am I like 100% successful in that? I will not say that, but I think I'm doing better by the day, understanding the pain generation. If you understand that the patient's possibly coming from some stenosis in the foraminal area, I think that we need to add that to what we're going to do to the TLIF area. Say if the patient doesn't have foraminal stenosis, just has instability there, I may even just go ahead and do a fixation, as you said, not an interbody cage, and the patient will be just fine. I'm like, the cage will be too much excessive. But I think at that point of time, I may think like, does the patient has a chance of having a pseudoarthrosis? If yes, I may say, okay, let's go ahead and possibly do a cage, because that will maximize or optimize the fusion potential.
Yes, it's selection criteria.
Yeah.
Good. So I love it when you say pain surgeon, because we see same thing, and I say to my patient, look, I'm not a life-saving doctor for you, but I'm a life-changing. Your quality of life will be different. So that is my role, that the quality of life, it's not a life-saving operation, so quality of life. So that is what makes a difference to you.
Like one of my mentors said that either you treat deformity or you create deformity, being a spine surgeon. So I don't want to be on the other side. So, when we do TLIFs and everything, I'm kind of trying to avoid any loss of lordosis. I think the cages are a very good instrument to prevent that loss of lordosis or even create lordosis.
Even a lot of people, if you see, general thing is, especially the cases you're dealing with, like elderly people, aging people, aging spine is a burden now. So we all see a lot of elderly people coming in, and yes, a lot of people try to do non-instrumented procedure for them, either a decompression or a decompression non-instrumented fusion, or a minimal. If they have to do a TLIF or something, it's a 1 or maximum to 2 level. And because they're creating deformity, adjacent segment problem and everything. See, a lot of people worry. So they try to keep it minimum as much as possible, the elderly, with instrumentation wise. I think that is our side of the, practice is like that. We'll just
Oh yeah, I completely. Even I do not venture into too much insertion of cages and everything like that. If the patient is elderly and osteoporotic, and and those patients do actually good if you their sagittal balance, even though it's positive, they do good with if they have predominant stenosis symptoms. I think they just do fine.
I think we are also taking that sagittal balance, sagittal parameters, even in for degen cases now, because we're as you pointed out, we are moving from just purely treating the local problem. We're also looking into the global profile in every patient we see. I think that is being adopted, and I think it will benefit the patients, and surgeons will, from our side, will understand more over the time, I think.
Okay, Murli.
Okay, thank you.
Amit is very tired.
Yeah. We'll have to move.
I mean, are you going in for a surgery right now, or Amit?
No, I'm done. I will be just going home.
Murli, Amit is so passionate that he gives the lectures in the operation theater immediately after surgery or before surgery.
But that is how we have to manage our time now. We cannot do it
not as passionate as you guys.
No.
Okay, Murli. If there are no
nice meeting you, Amit. Nice knowing you. Thank you.
Yeah, thank you, Amit, for joining us. And we look forward for another session whenever you have time. Maybe something like what Murli said about the sagittal balance, the CSPL, and all those stuff.
Perfect. Thank you, Hitesh. Thank you, Murli. Have a good night.
Thank you, Amit.
Murli.
Thank you, Hitesh.
Bye, Amit.